pleasure to be here. I had like 6 minutes to prepare this talk, so bear with me. But it is, I will agree with what Dr. Perea said, that it's not a debate, it's a complementary approach and it's a heart team approach. And in the end of the day, we do what we do for our patients. However, you know, TAVI has gone a long way. From the inoperable patients, it has FDA approval now for at least specific vendors for low-risk patients in the States. And that is a significant achievement since 2002 that TAVI first were presented as first in man from Alain Crembier in 17 years. And this has been done after a laborious work with many randomized trials. But let's start by example. This is an 83-year-old female patient with chronic obstructive airways disease and severe aortic stenosis. This is of the low flow variety with a preserved ejection fraction, as many elderly women in Greece have. So mean gradient of 35, valve area quite significantly reduced as a stroke volume. So preserved ejection fraction, but low flow, low gradient, and pulmonary hypertension, normal coronary arteries. The logistic Euroscore 14, the Euroscore 2 I think was around 4. And she was a candidate for Evolut R23, but this lady, I'm not sure if she's fully reimbursed in Greece under the current reimbursement status. So this is the STS score, risk of mortality of 4.4%. Nevertheless, it's a shared decision making with the patient. This is quite common now, especially in the States. If you look into the guidelines, clearly surgical replacement is recommended in patients with low surgical risk, the STS and the Euroscore 2 less than 4% or the logistic less than 10%. And of course, no other factors that we mentioned before, like frailty, porcelain aorta, chest radiation, etc. But when it comes to intermediate patients, so STS or Euroscore more than 4%, logistic more than 10%, and or other risk factors like the ones mentioned before, both options are available. This is a class 1 level of evidence B, with some factors favoring one approach over the other. So, for example, if you have an STS score of 4% and the age is above 75 years old and you have previous surgery, and of course the additional comorbidities like frailty index, radiation, porcelain aorta, etc., then that favors TAVI. If you have a younger patient, at least still according to the guidelines, you favor surgical replacement. So this is our patient. Small ventricle, preserved ejection fraction, calcium in the mitral, big left atrium. You can see that the valve is not really opening. This is the MAC. You see how much calcium in the mitral valve. And this is the Evolut R23 that was placed. Really trivial PVL and a very good result. Patient did exceptionally well, went home in 3 days. No pacemaker was required. Of course, this is not always the case with other patients. So these are the TAVI trials that give us the evidence to move forward. And we've moved, as we said, from the extreme to the high risk, to the intermediate, and to the low risk. The low risk trials are not, I will present in the end. Let's focus on the intermediate patients first, which are the patients more likely to be reimbursed in our country in the next months to come. And these are the two trials that actually the Partner 2 and the CERTAVI trials gave the evidence to move forward. Both of them were completed with equivalency of the results in both trials. Now, if we look into these trials in more detail, both of them were published in New England, and the populations, I don't want to go into the details of these two trials. I'm just showing the flow charts here and some of the modifications of the protocol, and we had the 2-year CERTAVI results. The only good way to actually look into these trials is to look into what sort of criteria one would use to choose one over the other treatment for the patient. So we have a patient and we're debating whether we're going to use TAVI or surgical replacement in a heart team. So of course mortality is one of these, morbidity is another one. The hemodynamic performance of the valve, is it good enough? Is it better? Quality of life, very important for elderly people. We have to remember this. You know, an 83 or an 82-year-old, even if it's an intermediate risk patient, you know, you don't want to spend 1 year recovering from major surgery. So I think we have to keep that in mind. Of course, durability of the valve, this is a big question. and patient acceptance. In the end of the day, the patient has a role to play in the decision making, and this is actually becoming more and more pertinent globally now. If we look into the evidence in the intermediate population, this is the mortality. We saw before in the slides that the evidence showed that both trials were TAVR was non-inferior to surgery in both of these trials for intermediate risk. But if you look into the cohort of the transfemoral access, it became very clear those days that there was a mortality benefit. Of course, this is a subgroup analysis, but still a significant mortality benefit in the patients using the TAVI. And the TAVI showed equivalent results. So really, going up to 24 months out. So I think mortality, you can give an edge for at least transfemoral TAVI for this population to the TAVI. We'll see about the low-risk population. What about morbidities? Now, morbidities are the strokes, the PVL, pacemakers, renal failure, need for transfusion, and vascular complications. It's very clear that when it comes to stroke, both trials, at least for the intermediate group, were actually similar, but when it came to the new version, the SAPIEN 3, in the SAPIEN 3 trial, the strokes are actually less. And when it comes to PVL, it's clear that the surgical valves are superior because you're stitching them, so they're much better. But really, we have to keep in mind that only when a PVL is significant, that carries a mortality benefit. If it's a trivial or a mild, it really doesn't matter. And of course, we have new iteration of the devices in both companies that produce the trials and also in other companies, that the newer generation actually reduce PVL, at least significant PVLs, quite dramatically. So I think we know at the moment surgery wins on that, but this is something that will be taken care of one way or the other. When it comes to permanent pacemakers, balloon expandable valves are better. Self-expandable valves, at least the ones that are annular, give a pacemaker rate of over 10%, up to 15% in some trials. So that's a problem, especially when we're dealing with young population. One has to think about the long-term, possible long-term results of the continuous pacing in these patients. However, there are improvements in these the designs, and there are other valves also that carry a very low pacemaker rate, around 4 to 5%. And of course, one has to think about the injury of the kidney, the renal failure after surgery, the transfusion, the need for transfusion, which is clearly superior to the transcatheter therapies. And also to the occurrence of atrial fibrillation. Clearly, we have more AF following surgery, and that might be one of the reasons why we get more strokes after 1 month in the surgical population. You have less atrial fibrillation in transcatheter-based treatments. So morbidity, I'm afraid, I think it goes both ways. Maybe surgery wins when it comes to pacemaker. I'll give 1 point to surgery, but when it comes to other things, clearly transcatheter therapy is also important. When it comes to hemodynamic performance, supraannular valves like the core valve group or the accurate neo group, because the leaflets are quite high up, have got much higher, significantly higher valve areas. And that is something that has been consistently shown by less gradients and higher AV areas as measured by echo. So I think that's also the patient prosthesis mismatch appears to be less of a problem for TAVI patients compared to surgical patients. So clearly the hemodynamics are not a problem when it comes to TAVI, and maybe that's an advantage for the future patients when it comes to low-risk population. Quality of life, clearly TAVI is superior because you have much quicker recovery from the procedure. The patients go out within a few days and they are mobilized within 24 hours. Clearly that's not the case with surgery. Well, what is interesting about the trials is that even after 12 months, the 6-minute walk distance is significantly better to the TAVI population. So especially when we go to elderly population, even for moderate, for intermediate risk patients, the recovery from surgery is delayed. You see patients 6 months out, 12 months out that really haven't quite recovered from the insult of a major surgery. So that's something to bear in mind. Quality of life questionnaires also show superiority, especially in the early recovery period following transcatheter therapies. And these are the data out to 2 years, even in the third TAVI trial for the 6-minute walk test. Of course, we have less stay in the ITU, less stay in the hospital, and that is impacting on the quality of life of these patients. And I think we have to correlate that with the patient acceptance. Clearly, a patient that knows that will stay less days in the hospital, less chance of spending more days in the ICU, having confusional and delirium stages, and traumatic experiences there, it's also something important when it comes to decision making. Before the low-risk trials came out, we had the 5-year outcomes for the Notion 1 trial. It wasn't actually a low-risk trial, but it was an all-comer, low-age trial. The patients that were actually recruited were less than 75 years of age. And that showed equivalency of the TAVI versus surgical procedures out to 5 years. And look at the stroke rate. So we had subsignals even from before. These patients were actually intermediate risk. Some of them were even low risk. Some of them were high risk, but were young patients. And again, the aortic valve performance as it came out was very good. And we didn't have any aortic valve, structural valve deterioration was not a big issue. When it came to structural valve failure, when it came to gradients, we had faster deterioration of the gradients to the surgical group because of the lower aortic valve area. The supraannular design of the core valve here was helping quite a lot. But structural bioprosthetic valve failure, as was defined in this trial, was equivalent in 5 years. So that was a quite significant. This slide was shown by Dr. Pereas before, and it shows the freedom from degeneration. We do see bioprosthetic failure in the surgical valve. I think the patent is the same. The patients without chronic renal failure actually did pretty well out to 8 years, but of course when they had chronic renal failure they didn't do so well. We have to of course see the long-term results of the registry data of the continuous expanding population, and that is an issue of course that we have to look out in the future. And of course, these were the core valve TAVI trials, the 1 year's results, the continuous access. The continuous access was actually focusing in the devised protocol that shows even better results. This Notion 2 trials is being planned for the low-risk population, but we had the publication of the Partner 3 and the Evolute low-risk trial, both in the New England Journal of Medicine. That's quite important. This is why the FDA at this year in April gave approval for use of these two valves for low-risk population. There was a lot of publicity actually was created by these trials, and clearly the primary endpoint in the Partner 3 trial shows superiority, or actually non-inferiority for the TAVR versus surgery. And when it came to death or disabling stroke, also there was a superiority of the TAVI population, and that was significant news. The mean gradients, as you say, were like that, and the PVL was significantly, of course, better with surgery, but most of the PVL was mild. And as I showed before, mild PVL doesn't really affect the outcome of these patients. When it came to the Evolute low-risk trial, again, the hemodynamics of the Evolute were superior compared to the surgical valves because of the supraannular design. And we had a similar patent of the quality of life in the at least early days in this low-risk population. Of course, up to 1 year, we had catch-up of surgery, but still the quality of life was better in the TAVI population. We do have enough evidence, I think, to push for TAVI use, at least in the intermediate group population. We could use it in the low-risk population, but of course we have to take into consideration other factors. Transfemoral approach is very important when we are talking about low-risk population, and of course bicuspid valves have been excluded, so we have to actually take this into account before making a decision about a low-risk patient. However, shared decision-making with patients is very important, and I think it's something that we will be facing in the next few years when it comes to decision-making about which method to use for the patients. So clearly, transfemoral approach is the one. We have faster recovery, better quality of life, less morbidity, and good hemodynamic performance for the TAVI valves compared to the surgical valves. Of course, we have still to improve on the TAVI models for the PVL and the need for pacemaker. And of course, it's already happening, but we have to watch and see the results of all this. Thank you very much for your attention.
Unfortunately, we're half an hour behind, so let's go forward. And please, Dr. Latios, please.